Thank you all for joining us. I'm going to begin with a couple of questions that are related for Dr. McCracken, I think, to begin, and they're on alternative treatments. One is actually a couple of questions asked about omega-3s and fish oil, and another couple of questions regarded the use of marijuana to decrease repetitive behaviors or ritualistic behaviors. So, Dr. McCracken?
Sure. So regarding omega-3 fatty acids, there were some, I don't know if you can hear me okay, there were some sort of clinical reports early on that suggested that might have some beneficial effects. Just recently, the results of some larger and more rigorous studies put that to a test. And unfortunately, the results suggested no benefit. That said, studies in ASD, ADHD, other types of psychiatric illnesses in North American children suggest that it's not so uncommon. Maybe 1 out of 5 kids in North America, given our diets, are low in essential fatty acids if you measure it. So it's something that for a particular kid, perhaps whose diet is very poor, supplementation might make sense clinically, but it's likely not going to have a big impact on their basic challenges from ASD. Regarding the components of marijuana, THC, and cannabinoids, these are actively under study. Dr. Kornblum perhaps can talk best about the recent emerging results of cannabinoids as a treatment for very severe refractory epilepsy. But thus far, they've really not been studied sufficiently to make a recommendation in ASD. I will only say that I have followed some patients whose family have sought out cannabinoid treatment, and I think it's going to be studied further, but we just don't know enough about it, both the safety and what the benefits may be. With epilepsy, I don't know, Harvey.
It's the studies are being done, and that's all I can say. The oils for the epilepsy component, it's difficult to say if any of it works at all. The drug agents with the cannabidiols the studies are underway, and there's likely that there's going to be some benefit in a certain percentage of patients. So we'll just have to see.
Okay, great, thank you. There are a number of questions about genetics, so I'm going to just start with a few of them for Dan. Several questions asked about having children. So one had to do with if I have an adult son with autism, doesn't want to have kids because he doesn't want to have a child with autism, what's the likelihood of that happening? And related to that, an adult whose SIB has ASD, would this warrant them getting tested or to be concerned about their own children? And individuals who are adults who'd been identified young as having ASD but had good interventions, now afraid of having children who might have ASD. So these questions all have to do with the risk of ASD if you've had a child or a sibling with ASD.
Yeah, so understanding what the risk might be, of course, one can start with a kind of detailed family history. And so these questions aren't as simple to answer as just sitting here and popping off a statistic off my head without, a lot of detail and a lot of discussion about family history. That's one side. So for these types of questions, especially where there's family planning involved, we recommend that people go see a genetic counselor who is expert in this area, and we can refer you to them afterwards. You can call the autism clinic here, the CAN clinic, and they'll refer you to the genetics clinic. because it's not really fair to give you a blanket. I'll just give you some rough, rules of thumb though, but this may not apply to a particular family. So the recurrence risk, if there's one child with autism, is, of having something on the spectrum, is somewhere around 10 or 15%, maybe as high as 20. Again, it's not precise. So it's, it's not negligible. If you already have 2 children with autism, that risk goes up substantially. So it would be at least double that. And the risk for kind of allied, but maybe less severe developmental language disorders or other things is also elevated and hasn't been kind of studied quite as much. The really critical thing is that, one can start with genetic testing, and in the event, the 1 in 5 event, we can, right now we can identify mutations in about 20% of people who have autism, kids who come roughly. In those, somebody who has autism, who's concerned, can get tested. If they find they have the mutation, a mutation, one can do testing, pre-implantation testing, right, to identify, and kind of, do in vitro fertilization, essentially, type approaches to actually, avoid having that particular mutation. That happens with a lot of other genetic conditions now.
Okay.
Yeah, did I?
Can I add just one other comment to amplify Dr. Geschwind's response? It's important that parents are aware that it's now an accepted universal recommendation that all individuals, as a part of a comprehensive evaluation, should receive genetic testing. And so that would hold even for an older individual who has a clear diagnosis, but who's never had more modern, at least first-level genetic testing, which is advanced quite a bit. So in the CAN clinic, for all newly diagnosed kids, adolescents, and young adults, genetic testing, at least at the initial level, is a blanket recommendation.
Okay.
I think it's going to be even more informative over time.
Yeah, I hope that was clear from the presentations today. That it's kind of becoming it's a standard of practice.
Here's a question for Dr. Laugeson. A lot of the social skills interventions require a high degree of language skills, receptive language and abstract concepts. Are there modifications to peers or any programs for kids with less language?
Absolutely, there are more interventions focused on those without intellectual disabilities, and so that's another area that's sort of lacking in the field. But we have actually piloted peers with kids with intellectual disabilities with IQs below 70. We don't usually go below 50. We haven't piloted yet with that group. And there's 4 ways that we would modify that program for that population. So number 1, we would simplify the lessons because as you saw, there's a lot of steps for things like peer entry, and so we'd have to simplify that. Number 2, we'd probably double the dose. So this is a 16-week program. We'd probably make it a 32-week program. We'd probably, number 3, use some visual supports. That's always very helpful. And then number 4, we would probably also have more opportunity for behavioral rehearsal. Behavioral rehearsal is practice. And what I've discovered in working with a lot of kids with intellectual disabilities and autism is that they often can use the skills, they can actually do the things that we teach them, but they can't necessarily articulate what they're doing. But with enough practice, they can absolutely use the skills. So those are the 4 ways I would modify the program.
Great, thank you. So here's a general question. There are 2 questions having to do with the relationship between autism and schizophrenia. What are the current studies' findings and investigations which explore the possible relationship options between autism and schizophrenia? And another, we see a lot of psychotic symptoms in autistic adults. Is there an overlap in the genetic influences that may explain this?
Yeah. So what we know right now is that there are very rare mutations that occur that increase risk for both schizophrenia or autism. They're generally not seen in the same patient. So a mutation might predispose you to having either schizophrenia or autism with some kind of risk. So there are quite a few of those, but they're rare. One example would be the velocardiofacial syndrome, which it used to be thought about a third of the kids will have autism, about a third schizophrenia. It used to be thought only schizophrenia. Now it's understood that autism, but some population studies that are coming out again from the Scandinavian countries are showing that it's actually, again, this is where the difficulty in family planning and genetic testing comes in, is that while a lot of the children, the majority will have intellectual disability and numerous other problems, the risk for schizophrenia, let's say, is only 2 or 3-fold or under 5-fold over the general population. The risk of autism quite a bit higher than that. But you get a sense that you have this major mutation and you can have kind of one or the other, generally not both. It's very, very rare to have, for somebody to have a diagnosis of both, and especially in large population registries, where it's something we don't see clinically a lot, so we have an impression. But in large population registries, where they have the entire population for their lifespan, you can look at people's diagnosis over their lifespan, and you just don't have people who have an early diagnosis of autism and then later have a diagnosis of schizophrenia. That's extremely, you do not see that more often than chance in these large populations. So although the common genetic risk, this polygenic background mixture, overlaps between autism and schizophrenia about 20%. To give you a yardstick for that, bipolar and schizophrenia overlap about 75%. So it's a small but substantial overlap, but the two disorders generally don't co-occur. So kind of understanding that, it's still kind of a mystery. If you're confused, we are confused too still. But I wanted to give you the real, scoop on that so that so that at least you know that it's a really active area of investigation. It's rare for schizophrenia and autism to co-occur in the same individual. It does happen, but it's not a common occurrence. And that there are shared genetic risk factors, kind of understanding how they cause one or the other, whether that's environmental factors, chance, or other genetic factors or epigenetic factors that haven't been measured. We don't know yet.
Great. Thank you. A couple of questions for Dr. Dapretto. First, a quick one. In the study with English versus Japanese language exposure, were all the mothers English speakers? And do you see differences between purely English-speaking mothers or households with bilinguals?
Yes, we had to control for that. All of the babies included in this analysis were exposed 90% to English in their before they were born and in their daily lives. So all of the babies had English as the language that they predominantly heard, both before they were born and after they were born. We have definitely a population of babies that are born in bilingual families, but not enough to start looking at how things may differ, because some of them maybe speak in Korean, some Spanish, and so on. But that's an interesting question. We definitely would not expect them to react the same way, obviously, because English would not be as familiar to them.
So one related question to that was, do you think that the response between English and Japanese versus Japanese would be the same between known English words and unknown English words, for example, due to the learning impairment in ASD?
If we were to look at older babies where there is clear evidence of word comprehension because they can point to pictures or give you an object that you ask them, I would suspect that we might. There are ERP studies using EEG technologies that have done those studies in toddlers, and they have seen different pattern of activity, if you want, for words that are comprehended to words that are not. But nobody has gone down as far as 9 months of age or in the first year. It's very hard to quantify comprehension.
Great, thank you. I got a couple of questions about stem cells for Dr. Kornblum. Could you comment about stem cell treatment and success rate, if there is any? And then related to that, there was a Duke study published in Stem Cells Translational Medicine where 25 kids received transfusions of their own umbilical cord stem cells, showed significant improvements in their autism symptoms. How do you see stem cells' role in treating autism?
So the answer is yes, I can comment.
And would you please?
So, okay, multifold question. Okay, let's go back to, so this idea of transfusing your own bone marrow stem cells. So the idea behind that originally was that you're going to replace some kind of cell in the brain with the bone marrow cells, and that turned out to not be true. There is some faint reason to think that that stem cell transfusions could play some sort of vague anti-inflammatory role in the brain, and that's just and that's speculation. There's some reason to speculate. So, while those types of studies are intriguing, I think that there needs to be a step back to figure out what is actually happening. Having said that, the risk there's little risk of your own stem cells being transfused back to you, but I also think that there's little upside to that either. In terms of doing the big things, replacing brain cells that are lost, or something like that, we don't know. We don't know what to do. We literally don't know where to put cells, what kinds of cells to put, and so that's more in the basic science realm. There may be some disorders where a particular type of brain cell or a particular type of neuron is lost, where stem cell implantations could have a little more of a role. But right now, today, when parents ask me, should I use stem cells? Should I go to Dominica or Grenada or something and get stem cells? The answer is no.
Can I ask a follow-up question? Should all pregnant moms request a sample of umbilical cord blood be saved for their newborns?
The answer is if they want. I don't have a big. It's well. There's a lot of issues with that. One is I don't have a. There are some situations where that may be useful, particularly in SIBS, and there are some disorders. But the way stem cell technology is moving, it will probably make a lot of that obsolete. It's an expensive process, and it's also not a high quality controlled process. A number, I don't know how many, but some banks have actually failed where they've lost cells. So I when someone asks me, I say it's personal choice. It's not inconceivable that the cells could be used. But there's a limited usefulness.
Thank you.
Can I say one? I just want to add one thing. The way Dr. Kornblum presented this, I hope that it's clear that when he says, we don't know, we don't understand this, that if somebody publishes that they do, you should, or tells you that they do, know where to put the cells, anything like that, you should be very skeptical.
Okay. A follow-up question? Yeah, sure.
Yes, just stay on the stem cell subject. The report on CNN, I think it's April 5th or 6th. Can you comment on that?
No, because I don't know what report you're talking about.
It's like they said they're using the ability.
It's a Duke study, 25.
The Duke study, yeah.
There are improvements in the.
Yeah, so that's what I was
That's that
referring
article.
to. And I think, as I said, it's not inconceivable that there are some improvements, but the way that improvement is happening, if it is unclear. So I look at it with a grain of salt, lots of salt.
That
1 ton of salt.
particular study was really a preliminary study. It did not have a control group, so one doesn't really know if the other treatments that the children were receiving had more to do with their improvement. And they didn't talk very much about the range of improvement. Only they did highlight a few kids that they said described as almost recovered, which made it seem remarkable. But one doesn't, one really can't accept that as a proof because it lacked a comparison group.
Yeah, in fact, we don't, you can't get a drug or new therapy past the FDA in that way because of what's called the placebo effect. There's this thing called placebo that's the most effective treatment we have for everything. And if you give the placebo, 60 to 70% of people improve.
Okay, perhaps in a not unrelated vein, there's an approach to ASD as a viral disease and being treated with antiviral medications. Anybody want to make a brief comment on that? Harley, want to say that out loud?
This is a common practice of some physicians in the community, and it doesn't have a real basis. And I'm concerned about it because many of these antiviral drugs are not innocent. They have some potential very scary side effects. So, in the absence of a documented ongoing viral illness, they are not considered to have any role at the present time.
Thank you. So changing gears a little bit, I have two questions about pediatricians' knowledge. One says, our general pediatrician seemed shocked by our son's ASD diagnosis. What is being done in the medical community to educate the average pediatrician? And related to that, how do we inform pediatricians of the importance of identifying ASD and knowing legal rights to early intervention? Amanda?
So, right, this speaks to my slide where we talked about universal screening is only being done in 10% of pediatric offices, and that is shocking. And I think it speaks to the need to raise awareness. And I think it goes down to, we are, at least at UCLA, are trying to, intersect with, trainees who are becoming pediatricians and train that next generation of pediatricians to be better equipped. I think that, I was quoted that they get, in all of their training, I think it's about 8 hours on, development or something. It's very low. And so that needs to change. And I think that needs to change from the top with regulations about their training down. But immediately what we can do as a community is really rally together and disseminate that information to them. And so some of what we're trying to do at UCLA is actually reach community providers of all types to give them more education about ASD and early symptoms. And we have some training programs ongoing if you're interested in learning about that more.
Here's a question for Dr. Lajonchere. Are you aware or can you recommend any app to help language improvement in toddlers?
So what I would do is, first of all, I've talked to Connie. But second of all, I think one of the things that I would do is go to Autism Speaks website and take a look at those apps and really find out, look at the ones that have evidence base. There are parents who there's also a Yelp type service where parents rank and rate the different apps, but really try to focus on apps that or programs that actually have evidence behind them. I don't know them off the top of my head. I don't know if Connie or anyone in your shop.
I don't think there have been any controlled trials.
No, that's the problem. I was working with a team at Vanderbilt to develop some apps to help more on the speech and language side of things to really help kids, preschoolers, to develop those skills. And it was more on a parent training than training the parent than training the child. So I would just really be cautious about apps that say that they have all of these effects. There are some that are being used clinically, where there's a therapist version and then there's a kind of a parent home-based version. Again, because a lot of the things that are taught in the clinic, they need to be reinforced at home. And so people are really focusing on tools that can translate from the clinic into the home. Connie, do you want to elaborate?
Well, I would just say that with a toddler, it's probably clear that the app needs to be used in the context of an intervention that involves a parent or a therapist. So it's therapist or parent mediated, and that you just don't give a toddler an app and expect that they're going to learn from that. Right. So there are programs that are speech related, and we use one called Proloquo to Go, but that's kind of expensive. There are knockoff. Sounding Board is free, but it's really used in the context of the intervention, and those can be helpful, and we do have some evidence that those work, at least with language learning children.
Okay, we've got two related questions. Can a normal child get autism later? And if an autistic child gets better, can they ever regress? Connie, you want to take that, or Amanda?
Or maybe Amanda.
Oh, well, I think not in my years of practice have I seen a completely typically developing child just all of a sudden develop symptoms of autism. No. So there usually is a developmental trajectory, and it is sometimes quite subtle, and so it is hard to detect. But if we do a careful history and a careful interview with that parent, and even look at videos from early on, first birthday parties is a time where most parents have those videos, we usually can detect very subtle issues around social communication that will predict that diagnosis later. So I have not seen that type of a case. And what was the other one?
If an autistic child gets better, can they ever regress?
So regression is kind of a scary word, and it's a pretty severe word to use. I think that, the developmental trajectory of individuals on the spectrum waxes and wanes with development. And so I like to think of it as, a child at different points in their development may hit some roadblocks. And so they may suffer some setbacks. And there are some key times where we may see that. Entering into school, for example, entering into adolescence. These are times where this is very stressful for the individual. So I wouldn't consider it regression, but there are times where we may see, loss of skills or specific challenges coming up, especially with onset of things like comorbidities.
Right, thank you.
So definitely there are a number of kids who make enormous progress, who can achieve very high functioning lives, who undergo rather scary and acute deteriorations. When we see that, it's not uncommon. The first thing we think about are depression, anxiety, related new onset of psychiatric symptoms. They may not have a disorder. They may have fewer symptoms than necessary to meet a diagnosis, but kids can be pulled down by the onset of these common comorbidities that are super important to recognize because they're treatable, and you can get kids back on their feet again, whether through targeted psychological therapies or sometimes medication. So it's not uncommon, to be sure.
Just to be clear for those of you who may not have been here this morning, if there is a child who is seemingly normal and has a regression and some of the features of that may be autistic, that's a child that needs to come to medical attention and a prompt evaluation because of the things that I spoke of and some other things that can be somewhat masquerading as autism in this day and age, also because there's such a power to get the diagnosis that there's some other things that need focusing on. So if that happens, that child should come to medical attention promptly.
Right. So epilepsy can indeed occur in adolescence, right?
Yeah.
So new onset seizures would be another thing that should be at least thought about in such a case of an acute change in functioning.
We've got several questions about gender differences in treatment outcomes, one for peers and then several just generally. Are the treatments that you've spoken about today equally effective for girls and boys? Liz, you want to start?
That was a timely question. We just had a paper that was published recently by Elena McAvee out of Marquette University looking at gender differences in peers' outcomes, and there were no differences. We've also found that in our own research and looking at also not just gender, but also age and level of functioning, IQ. We've looked at all of these different things, and we're not really finding that any of those things predict treatment outcome. But we also have a selection bias in that we're including a very specific group of people. These are adolescents or adults that are socially motivated. They want to be there. They're not so socially anxious that they can't participate in treatment. They're not so depressed that they can't participate in treatment. They have a certain level of functioning already in terms of language abilities and IQ. So you have to keep that in mind that, we have a very select group of people. But in general, the only thing that we've found that's predicted treatment outcome in peers with that, again, selection bias is level of social functioning when they come into the program. And this is not actually intuitive. I think it's counterintuitive. Most people would think, from a research perspective, that those who had poorer social skills would do better in the program because they had further to go. That's actually not the case. And the clinician in me knows that. The researcher in me is puzzled because it's actually those who come in with a little bit better social skills that actually really blossom and thrive and do very, very well in the program. Everyone seems to be doing well, but those are the ones who benefit the most. So that is a very important thing to look at, though, the predictors of treatment outcome and who's most likely to benefit from treatment.
What about Jasper, Amanda, or Connie?
Jasper, no differences. But I think for peer interactions or social skills group, there are fewer girls that are diagnosed, so we do have to think about who you put together in groups. And a girl in an all-boy group, at some point, that just doesn't work, right? And so we do, one should think about how you would adapt an intervention that's sensitive to girls' interests, puts girls with other girls. And again, their issues are a little bit more subtle so that they can camouflage. And so there are some things to think about. I don't think we've had very specific interventions for girls versus boys, but it may be something in the future we should think about.
Regarding medications, I'm embarrassed to say we've enrolled too few girls in almost all of our studies to make any conclusion about sex differences in response to those treatments.
Quick follow-up question. Do we see an exacerbation of symptoms with onset of puberty and hormonal changes in autism? And what would you suggest about that?
Stay young.
No one wants to talk about puberty.
Yes, I would say in general in the clinic. I mean, it's a difficult, challenging time in development. It's a time where, the onset of potentially comorbidities happen. There's hormone changes. In our team, we talk a lot about the developmental period for a patient and how, in those teenage years, it's difficult for a lot of reasons, but hormones are definitely involved in that, for sure.
Okay, I just want to get through a couple of questions before we have Dan wrap up. Dr. McCracken, is there something in the chemical structure of Abilify or risperidone that makes them different than other second or third generation antipsychotics? And do you ever have any studies of cocktails of medication?
So risperidone, it has quite a bit of similarity to other medications in the same class, which would be considered the second generation antipsychotics. They affect dopamine, they affect serotonin quite similarly to many other of the commonly prescribed antipsychotics. Abilify or aripiprazole is relatively unique, and that was one of the reasons that we chose it for the combination Jasper study. Based on its mechanism. I think overall the benefits, if you were to compare the two head-to-head, aren't that great. Both help the majority of individuals who have that irritability, aggression, self-injurious behavior set of symptoms. But we hope that we'll be able to sort of capitalize on the subtle difference of the aripiprazole. We'll find out from the results of this study. Combining medications is very, very common in clinical practice. I think some of the surveys suggest that anywhere from about a quarter to a third of kids on the spectrum in a wide variety of treatment settings are taking more than one psychiatric medication. The problem there is that we really haven't studied those combinations very well to know how beneficial they can be and importantly, their long-term safety. What concerns us in the CAN clinic is that it's not uncommon to see new patients who come to us not just on 2 medicines or 3, but 5 or 6 medications, and where no one can really disentangle the purpose, the effect, the side effects of all 5 of those. So often treatment begins with a process of culling and cutting back on those medications because some of them really do have serious long-term side effect risk, particularly the antipsychotics. There can be a rationale for such combinations, but we encourage a very conservative approach where if at all possible.
Okay. All right, so I'm just going to ask one last question. There are a few that we haven't gotten to, but I think our speakers will stay around afterwards if you would like to come up. This is for Dr. Kasari. It's a 2-part question. First, does an IEP have effective results for teens' behavior? And second, do specialized schools such as a Frostig school, which has a whole group of ASD or AHD kids, have better outcomes than general education regarding the treatment of behavioral change?
What was the first question about an IEP?
Do IEP programs have effective results for teen behavior?
Oh, yeah. So on your IEP, you should have some social goals, and you as the parent have to make sure that those goals are being addressed. Honestly, you can call an IEP at any time. So you should make sure that you have social goals. You should make sure that they're addressing those, and you should follow up if, in fact, that's not happening. Do schools that are self-contained have better outcomes? I have no idea because they have not published those results. There's a lot of marketing, and people will market and say that things are happening. It doesn't mean that there aren't good programs in self-contained schools. And again, you could have your best friend be more like you, another child with autism. At the same time, you can have lots of different kinds of friends. So it really depends on the individual characteristics of that child as to what the best fit is. And something else we didn't talk about, we've done a lot of studies on the size of groups and the differences for boys and girls. So boys do better in smaller classrooms in the early grades, kindergarten through 3rd. Girls do better in larger groups at 4th and 5th grade. And you can imagine that there might be more options for girls if there's a larger class, whereas boys need a smaller one. But we've done this with a few hundred kids, and it's been replicated. So it does seem to be something about class size and gender.
Okay, thank you all, and please join me in thanking our expert panel.